Hi, Mike Gibson, Jonathan Reiner here, talking about the CDC changes. Jonathan, talk to us a little bit about some of the missteps so far in the pandemic. What were they? What needs to change? And what's the path forward?
So unfortunately, the CDC has been plagued with missteps from the beginning, starting with testing. So we can talk about that. The CDC actually had created a test to detect this virus fairly early on in the pandemic in the United States, essentially before really there was much of an outbreak. But for reasons that are still unclear, CDC decided actually to manufacture the test on their own. And in so doing, the test was actually contained a contaminant. So shortly after rolling the test out to sites around the country, it was clear that that test was contaminated and was pulled. And that really delayed testing in the United States for almost 2 months. So about 50 days after the first patient came to the United States, the US had only tested about 30,000 people, which was obviously just inadequate. And that's at a time when the virus was, traveling around the country on trains and planes and buses and subways, and at a crucial time where we might have been able to do much better containment, contact tracing, we didn't really have the ability to test. So that was sort of one of the seminal mistakes that came out of the CDC. The other important issue to remember is that although we'd like to look at the CDC as this preeminent international, depoliticized, apolitical organization with the best scientists in the world, and I think we do have the best scientists in the world working in the CDC, career scientists who've spent their lives devoted to public health. The agency has become politicized over the last several years and has found themselves subject to pressure from the West Wing and both administrations. And I think we've seen this starting in the prior administration and continue into this administration. And we can trace decision after decision back to political pressure, again, in both administrations. And I've been a pretty vocal critic of the Trump administration's response to this pandemic, as well as the Biden administration. We can go through some of these point by point. But I think when we think about how to reimagine the CDC, and I'll say at the outset that I admire Dr. Rochelle Walensky for coming out yesterday and acknowledging that the CDC really has fallen short. I think that the first thing to do is to try to depoliticize the CDC, and
Yes.
maybe to do what the US has done with the Federal Reserve and in some ways with the FBI, basically decoupling the tenure of the leadership, of the appointed leadership of those organizations from, presidential terms. So, the chairman of the Fed and the FBI directors both have tenures that aren't limited to a current administration. We should do the same thing with the CDC. We need to really create political firewalls to insulate the director and the professional leadership from pressure from the West Wing. And we've seen in both administrations enormous pressure exerted on the CDC to either withhold data or provide favorable data or make politically advantageous recommendations or policy decisions based on the whims of the administration. And I think that's the most crucial initial need is to depoliticize the CDC. And there are multiple examples. We can go through examples in both administrations about how the CDC, I think, has been pressured to.
Let's focus on the path forward. I mean, this would be a legislative approach to decouple them. Is that correct?
Well, I think we need to have a CDC director who feels like their tenure is not at the whim of either the West Wing or the Chief of Staff or the President of the United States, that they're there on behalf of the American.
But what's the path to accomplish that? I'm sure that would require a congressional act, correct?
Right. Probably a congressional act to create sort of a politically autonomous leadership of the CDC. Right now the CDC director obviously is responsible to the Secretary of HHS and ultimately to the West Wing and the President of the United States. And it's an enormous amount of pressure. It's an enormous amount of pressure.
What else needs to be done?
I think the CDC needs to do a better job of communicating to the public. I think they have shockingly, fallen short of being able to communicate good news and bad news to the public in a way that fosters trust among the public. Some of this was,
isn't it? I mean, it's tough because things are changing, right? I think if we had been a little more forthright about some of the uncertainty at moments in time, that this is what we know now, and you can expect this to change, perhaps. I think conveying some of that uncertainty and letting the public get uncomfortable with the fact that there's some uncertainty might have been a better path. Do you think?
I completely agree. It's impossible to talk about this pandemic without understanding that when it came to this country, it came to this country in a presidential election year. And it came to the country at a time when there was great political sensitivity about what effect pandemic mitigation strategies would have on the economy and on the economy in an election year.
Sure.
And when you look at how disclosures were made to the public in the early months of the pandemic in the late winter and early spring of 2020, it's clear that there was enormous political pressure to try and spin a narrative that made it look like the pandemic would be no big deal or be very transient, go away very quickly. Famously at the end of February 2020, Dr. Nancy Messonnier, one of the leaders of the respiratory branch of CDC, came out and briefed the public on what she expected was going to happen in the country. And it was really the first stark description that we were likely to need a lockdown and people need to start how to think about working from home, and schools were going to likely be remote, and families need to think about maybe stocking up on some food for a while. And that's the last you heard from Dr. Messonnier. So I think when you see elements of public health leadership being muzzled, that goes a long way to create doubt about the truth of what we're hearing.
Again, that's the first issue discussed, that this needs to be autonomous. The second issue, though, is the style. I guess you're saying that the autonomy, in turn, colors the style with which things were communicated. But if they had been able to communicate in a forthright and transparent fashion, I think more rapid communication, clearer, simpler communication, perhaps, and conveying that, things can change. I think we as consumers and people in the public want certainty, but I think we've got to educate the public that things may be uncertain for a while. Is that right?
Right, I completely agree. And we were getting information filtered through the West Wing of both administrations.
Sure.
And rather than having information filtered to the public through political appointees,
Right.
be hearing information from physicians and scientists.
Right.
And, and doctors should be truth tellers. Everything, we teach this to our medical students and our residents and fellows. Everything that comes out of a physician's mouth needs to be the truth. That's how we breed trust. And in a pandemic, public health officials are going to ask the public to do some difficult things. If you go back and read the history of the 1918 pandemic, these lessons of what the public needs to hear resonate now, and the public needs to trust the nation's leaders and the public health leaders. And if the public isn't getting the truth, then there is no trust. And
Right.
I think trust. I think that the first casualty of this pandemic was the truth, and then the next casualty of this pandemic was trust.
Yeah. I mean, once you
So,
lose trust, it's all over. I think that was the first big misstep. Yep.
and the CDC in the summer of 2020, when there was a strong effort to try and get kids back in school in person in the fall of 2020, the CDC, the West Wing, pressured the CDC to create a document much more favorable to school opening. And if you remember that document from the CDC, literally the first paragraph, the introductory paragraph, focused on sort of the mental health of children, obviously an important topic, but rather than focusing on the biology of the virus and the infection rates in kids and hospitalization rates in kids and spread to vulnerable members of households, the CDC issued a very politically sort of tainted document on school opening. And CDC can't do that. CDC has to simply be a public health agency.
Right.
The CDC has collected data from the beginning of this pandemic, very, very granular data, and has shared it very sparingly with the public at large and with the medical community in the United States. Data on vaccine efficacy by age and race, information that would be helpful in understanding populations at risk.
And we kept turning to Israel for their data.
Right, exactly. And the prime example of that was the CDC collected data on breakthrough infections, and again, with a lot of granularity. And when we were trying to understand groups that would benefit from booster administration, the data wasn't available. And we relied on data coming out of Israel.
Was it not available, Jonathan, or was it there, but they were sitting on it because they wanted to have absolute certainty or clean the data or whatever before
It was there.
Yeah,
it was there. And so for instance, when we first started to see some
another issue, right, Jonathan, that we need a more rapid process to review and gain comfort, maybe not certainty, but comfort with the data and release that data more rapidly during these scenarios. Is that
correct?
true?
But remember, the CDC has been accustomed to publishing papers.
Correct. Yes, this is not an academic. This is a public health emergency, not a publication pathway.
Exactly. So it's like having a rapid response force. So
Correct.
you need a rapid response force to get the best data possible, acknowledging that maybe the data will change, or maybe some of the interpretation of the data will change. But if you get this data out almost in real time, then in our current environment, you have the ability to sort of crowdsource the interpretation of this data. But the CDC was, I think, a bit hidebound, and their infrastructure required them to do these exhaustive analyses on the data, and basically, internal peer review on the data. And then again, don't forget that data then gets filtered through the political machinery. And the prime example is when the first data we saw on boosters was essentially, the only data we saw was like 65 and above.
Mhm.
And they omitted any data on 18 to 49 because I don't think they wanted to. I think their concern was they didn't want to dilute the public's understanding of the necessity of boosters with data that maybe was less robust or less supportive. So they selectively release data. Another example is
A political decision or a communication decision on the part of the CDC?
I think it's both, but I don't think any decision that has come out of the CDC, in either administration, can be divorced from politics. And maybe we can talk about some of the policy decisions that CDC has made. But one other striking example about selective dissemination of data is wastewater data.
Mhm.
So communities like where you live have been collecting wastewater data from the beginning of the pandemic.
Yes.
And that kind of data was only made public or easily or in a kind of a central way from the CDC this past winter.
Yeah.
Despite the fact that communities have been collecting in parts of the country, like Massachusetts, parts of New York, other parts of the country, have been collecting this data from the beginning, and the wastewater data was early warning.
Right.
And imagine if from the start, not only did the CDC disseminate that data, but also encouraged communities to start to acquire wastewater data, that would have given us much more a greater capacity to have early warning in communities before hospitals started to fill.
A little bit like what we're seeing now with polio, with New York.
Exactly.
Mhm.
Right. With polio in New York or monkeypox, starting to use that kind of data to help communities plan for outbreaks rather than respond to outbreaks.
Jonathan, do we need to switch from the CDC trying to do everything to being much more engaged as an emergency response team? As Gottlieb has suggested, maybe take smoking, have another agency do that, have the CDC focus on these infectious disease emergencies. Or do we need to carve out a piece of the CDC that's more reactive and responsive? I mean, what's the right way to do this operationally?
Well, I think the question you're asking is the task that the CDC has now too great for any single agency?
Correct.
And do we need mostly now or most urgently now, do we need a infectious disease, as I said a moment ago, rapid response force?
Correct.
Not just responding to pathogens, but disseminated around the world, looking for early signs of disease activity in countries around the world. And the CDC does that, actually. That's been one of their sort of magnificent capacities over the years, is to go into places in conjunction with the World Health Organization and identify potential emerging risks to this country. Right, and maybe we need to refocus the CDC into that and let some other agencies deal with, publishing heart disease stats and, right, as you said, smoking stats. But if we look at some of the decisions that the CDC has made over the policy decisions that they've made over the last year, it's hard to look at these decisions without looking at them with political glasses on. So when it became, so let's start with boosters and the definition of fully vaccinated. When it became clear that we were going to have to, people were going to have to get additional doses of vaccine, the CDC had a decision to make. They could, the country had sort of stalled at about 75% what they called fully vaccinated, meaning two prime doses of an mRNA vaccine. Do they redefine fully vaccinated as vaccinated and boosted, which is what I favored, and I think many people favored, or do they leave it as it is and then create this narrative that they called up to date, right? Fully vaccinated and up to date. And what they really did was, if they had changed the definition of fully vaccinated to being vaccinated and boosted, if you were eligible to be boosted, it would have forced them to basically publish data that showed that only 30% of people in the United States were fully vaccinated. And that's kind of a politically harsh reality, right? Only 30%, but that was the truth. And if you're trying to help the public understand why more people need to be vaccinated, maybe you need simply to tell them you're no longer fully vaccinated if you're not boosted.
Mm-hmm.
And these were the kind of decisions that I think were made with a heavy hand of politics. In the when the CDC revised their recommendations for going back to work after infection, those decisions were made in response to the very loud public complaints from industries like airlines. And CDC came out with a policy that said you can go back to work 5 days after testing positive, whether you're testing positive or not. Hard to think that there wasn't a heavy political hand on that scale when that decision was made.
Particularly knowing
and then
half of people were still positive after 5 days.
Right. So the average, particularly for Delta and Omicron, I think people on average were positive for somewhere between 7 to 8 days.
Right.
And I think CDC could have made had a compromise and said, look, you can start testing at 5 days, and when you test negative, you can go back. You can go back before 10 days if you test negative. But they chose not to do that. And I think the most glaringly political decision that came out of CDC was when they changed the map in February of this year. So CDC made a conscious decision to pivot away from looking at case rates and instead turn to looking at the impact of cases on the community, which makes sense if you're a community and you're looking to understand whether maybe you need to reinstitute masking if your sole criteria is hospital capacity. But when the CDC changed the map by basically creating a metric that looked only at hospitalizations and ICU capacity, that's what the entire community level is hospital capacity. They basically created a fiction that the pandemic was going away, despite the fact that, if anything, the pandemic was accelerating. So overnight, the map turned from red to green because hospitals had a lot of capacity, but people were getting infected. People were getting what we used to call breakthrough infections. And if you were an individual,
Which totally discounts long COVID and the chronic impact of these infections, by the way.
Absolutely, right. Discounting, and also discounting the fact that the US never really dropped much below 400 deaths per day.
Yeah. Well, that's one of the things I asked on one of my polls is if we're at 500 a day, 4 or 500 a day and a 180K a year run rate, is that acceptable from a public health perspective? I mean, we're talking multiples of flu season. And
Right.
most people said no. I mean, 2/3 of people said no, right?
Right. So I've had epidemiologists suggest to me that if you're looking to use uh, mortality rates to help understand whether we're sort of entering an endemic phase of this disease, then the number to look at is about 100 deaths a day. Because in an average year, we'll see about 35,000 deaths from influenza. So if you're looking to see on a public health perspective, the impact, yeah, about 100 deaths per day would get us into what would be sort of a typical flu season, and we're 4 to 5 times that now. But by changing, but if you're an individual, and there's been this movement to place responsibility on for mitigation on the individual, you decide what your risk is, and mask up if you want. But if you're trying to empower individuals to make these kinds of decisions, knowing what the hospital capacity is meaningless. If you're trying to understand whether when you go out to buy a gallon of milk this afternoon in the supermarket, whether you should have a mask on in the store, the only thing you care about is how much virus is in your community. And CDC made it difficult to know that.
Yes, that's a very good point. A very good point.
And I think that has propagated this surge in the United States because it created this fiction that the pandemic was going away at a time when the virus was continuing to mutate and cases were accelerating in this country. But when you looked at the CDC map, you could not tell that. In fact, we were told the opposite. So I think we're in need of sort of a chief, medical communications officer.
Yes.
Somebody who just basically says, look, here's the data. This is where the cases are. This is where, we're starting to see things get a little better. This is where things are getting worse. And, as we're getting ready to open schools now, again, in kind of a hard to understand way, CDC has not given clear guidance to communities, I think, about how to do this safely. And they've done the opposite, so they've removed any kinds of social distancing, cues from the guidelines. So the 6 feet is gone, which means now in schools, kids will be close together. They're not urging masks in schools, except if there's a sense that maybe there's a surge in the community. But again, they're not giving communities the tools to actually understand what the true infection rate is. And again, I think for citizens in this country and businesses and parents trying to get kids back in school, they just need to know the facts. They need to know how much virus is in their community, whether the current strain is as dangerous or more dangerous. They need to know the straight up data supporting vaccines. Look how poorly we've disseminated vaccines to children, right? If you look at, forget about the youngest age where we've barely vaccinated any kids in this country now. But if you look at 5 to 11-year-olds, only about 30% of 5 to 11-year-olds have gotten 2 doses of a vaccine. And so because we've been ineffective at communicating the truth, the misinformation sources around the country have been very effective.
I think being a chief medical communication person would be easy if you could speak transparently without the political pressures that you're talking about. So, but to kind of sum up, is it fair to say the process or the office or the entity needs to be depoliticized, needs to be uncoupled from the West Wing. That would probably be a legislative act to get them there. That they need to be, I think, much more rapid in communicating what they know and communicating the uncertainty with which they hold those results. They need to be simpler and communicating in ways and language that people understand at that kind of eighth grade level across the board. And they need to have a better surveillance system. I take advantage of the surveillance systems that we have in places like Massachusetts with the wastewater. Uh, but I hope we can get there, Jonathan. I mean, we learned a lot from this, and we in the trials community did a horrible job as well. We must get our infrastructure organized so that we can quickly organize the trial and get it done. I mean, we don't need to redesign case report forms. We should have those case report forms designed now. We should just be able to hit a button and begin collecting data so we can randomize people to know if these therapies are effective or not. So it's not just all on the CDC, it's also on all of us to, make all of us more responsive in these scenarios. Jonathan, thanks for taking time out for talking today. Very, very thoughtful. Appreciate it. I'm going to have you on more and more. And thanks to all of you for joining us here today.
Thank you, Michael. My pleasure.